Good afternoon. I'm Dr. Rick Wadas, the Regional Medical Director here at EMS West. And I have the pleasure today of being with Dr. Dan Bledsoe, Commonwealth EMS Medical Director, who's going to give us some time today to talk just about a few issues over the next several minutes. Welcome, Dr. Bledsoe.
Thank you, Dr. Wadas.
Would you be able to just tell us a little bit about your background in EMS, maybe how you started, and then what your EMS experience and career has been like to now?
It's been an interesting journey. I think like a lot of people that are EMS physicians, I started very young in EMS. I grew up in a volunteer firehouse in Southern West Virginia. I always knew I wanted to be a doctor, and I was able to have the privilege of being a volunteer firefighter, attended EMT class with my sixth grade spelling teacher, believe it or not, and became an EMT, worked my way through undergraduate as an EMT, volunteered for my campus rescue squad in medical school. And there were not a lot of emergency medicine residency seats in West Virginia, so I pursued my residency in Pennsylvania, and it became home. And I've been blessed to serve with a number of great EMS services and ultimately was selected to be the EMS medical director.
That's great. It's a similar story to my own in many ways, I'll say, and I think it is, like you said, for a lot of us. I have had the great experience of being able to work with you for the last year or so since you became the Commonwealth Medical Director. And you came in at a little bit of a turbulent time. We were in the middle of a protocol revision. And so I thought asking a little bit about that with your fresh look on how the protocols are revised, who participates in that revision, how long does it take, and how does that process all come to be before they're actually released to our providers?
I think the biggest thing to say about that, Rick, is that you don't know, nobody knows how much work goes into it. And I thought it was going to take more work than I thought it was going to take, and I still didn't think it was enough. There are a lot of hands that touch them. We have our, PEHSC, the Emergency Health Services Council, is the advisory board to the Bureau of EMS. And they have a medical advisory committee. Each regional medical director, you and your 12 other colleagues from around the Commonwealth, plus 5 specialty representative doctors from the State National Association of EMS Physicians chapter, State Emergency Physicians chapter, trauma surgeons, EMS for children with a pediatric emergency physician, come together and represent specialty patient populations as well as the regions of the state to advise and just tweak and refine those protocols and decide when it's time to bring more into whatever it is that our scope of practice is, or sometimes to say something's not working anymore and it's time that we shouldn't be doing it in EMS anymore.
One of the questions that I frequently field is with regard to what level of procedure protocol does a particular provider sort of practice to, and what kinds of things go above the medical command line versus below the medical command line, and how is that decided?
I would consider that a two-part question. I go to the first part of the question, which is, how does each level of provider get set at a level? And, ultimately we have our national EMS scope of practice, which is a consensus document that comes together from a lot of national stakeholders and state EMS offices. That's ultimately what you're taught to. And so myself as an emergency and EMS physician, I'm not going to do open heart surgery. I've never been trained to do it. We wouldn't expect an EMT trained at that level to start an IV and endotracheal intubate because they weren't trained to do that. And the entire process, our nationally standard curriculums, national registry testing are built around that scope of practice. And so I think that's sort of our ceiling at every level, is that national scope of practice. And then historically, and again, being relatively new to the position, with the input of the advisory board, with the input of other stakeholders from around the Commonwealth, some things have gone up, some things have gone down, and we have the system that we have today. As far as above and below the line for medical command, I think there's a lot of inputs there. Sometimes it's just a low frequency, high impact skill where errors are common. And it's the medical command doc becomes your sounding board, your drug calculation checker. That extra couple of minutes gives you the time to check up and know that the procedure you are aiming to do is the right one to do. Sometimes it's just that extra ability to convince a patient to go to the hospital. The consult for refusal list exists because a lot of times it's something that patient probably should go get checked out. And ideally, the doc could get involved and try to help that patient be convinced to go.
We are seeing some changes in scope of practice this year. We were earlier today just talking about the check and inject process for EMTs for epinephrine. How does the scope actually get changed, and who ultimately decides how that occurs and what they're going to do?
Ultimately, it's a decision process that goes through the Department of Health, and the Secretary of Health signs off on things that are published in the Pennsylvania Bulletin. If you go to the health.pa.gov to the EMS Bureau website, and all of our sites have changed. All the old health.state.pa.us websites are going to come to an end around May, and everything's going to go to pa.gov. So just for future reference, but you go there and you look at the PA bulletin. Ultimately, it's the Secretary of Health's decision, and the Bureau of EMS advises the Secretary with the counsel of that Medical Advisory Committee at PEHSC, which is each region's medical director plus their specialty-specific docs, so that we have hopefully a global, or at least, from Lake Erie to the Delaware River, a wide perspective on how it's going to affect everyone in our Commonwealth.
That's helpful. One of the other things that providers in our region will often ask about is, how do we implement a new device or a new process or new procedure? For instance, we have a pilot right now in our region looking at the administration of nitrous by BLS providers. How do those processes come through the region to the state, and then how do they actually get the thumbs up to proceed?
Generally, if an agency wants to try something new, that agency is going to work with their medical director, build the proposal, figure out how they want to do it, and then it escalates into the Regional Medical Advisory Committee, and a body that I sat with just today, here in EMS West. Plum EMS asked to join the City of Pittsburgh buprenorphine initiation program and that pilot, and that pilot is going very well. It was last year at this meeting that some services here in the Western region, I think Quality EMS was the lead.
They were.
And so they proposed the nitrous, and ultimately that goes through. If it's something that big where we're changing scope, we're adding a drug to a different level of training, usually a regional medical advisory committee is going to escalate that to the state. And so that state medical advisory committee comes together with more regional voices, and based on that recommendation, then it goes to the Bureau of EMS for a final decision. Ultimately, it's a director's decision. As a medical director, provide the advice, and we issue an approve or disapprove decision. But a lot of that is looking at, why are we doing a pilot? What are our performance indicators? Should we just change the entire scope? Sort of how we went with blood. We skipped the pilot phase and just went directly to working with blood. We have neighboring states that are doing it. We have neighboring nations that are doing it. It's in the national scope of practice. And each region and each service is going to have to do it very differently based on their blood bank resources, based on their vehicle resources. And so we just felt it was better to unleash that.
Yeah, I've been either the associate or the regional medical director now for probably almost 2 decades. I can say that whatever process changes have been made seem to really be working, because I think these most recent pilot programs that have been put out there that have been well thought through, well presented, have gone through an efficient process with timely turnaround. Even when there's feedback for adjustments or a need for more information, that's gone back and it's been adjusted, and then it's come back again. And I think that process seems to be working really well. So thank you to yourself and Director Martin for honing that process for us here in this last 6 to 12 months.
Yeah.
That's been great. I appreciate that.
Thank you.
One of the other things that we often talk about, and it's along that similar vein, is with regard to new devices that come on the market. You'll see today in our exhibit hall here, there will be demonstrations of all kinds of new gadgets and gizmos to help providers provide either new care or the same care in a different way. And so how do we as a system evaluate those devices to help determine whether we think it fits with the rest of our protocols and procedures here in Pennsylvania? And then how do we move those along to make them available to our providers?
I think previously that's been done very case by case, and I think one of the hot button pieces of that is which supraglottic airways we use and which we don't. And I remember when laryngeal mask airways were really coming into use, and I was in medical school. And the original laryngeal mask airways, which look very much like your iGel, like your Air Q3, like your King, those airways were very hard to insert. You had to seat them just right. There was an inflation trick you had to do by curly cueing the bottom up. And if you didn't practice that regularly, and you think about, anesthesiologists and anesthetists in hospitals are using those every day for colonoscopies, for other sedation procedures. That's pretty easy when you're doing it every day, but it's a relatively, low frequency, high impact skill for us. The King LT sort of revolutionized that space. And again, and I speak from my understanding of history, having been a guest of the medical advisory committee and attending a lot of the meetings, that when that came out and it became a much simpler blind insertion device, that we enabled blind insertion devices by name, the ones that were easy to do in the low frequency environment.
Right.
And then, the iGel came along again with that self-inflate, or with that elastomeric cuff that is just there and molds itself to fit. That was one that was approved because of its ease of use, because of some improved outcomes in cardiac arrest suggested by some research. Ultimately, and Director Martin and I are on the same page with this, we'd like to have the Bureau out of the business of naming devices.
Right.
But on the same side of things, there are some places where you do need some form of device control. We say control bleeding with a tourniquet. Okay, we don't want to use an IV tourniquet that just provides venous pressure. And, TCCC, there are approved tourniquets that they use. There are other tourniquets that have been proven under fire not to perform adequately.
Right.
And so there is a fine line between something might be approved by the FDA, which is sort of your first line of defense. You have a medical device, the FDA approves it and finds it to be reasonably safe and effective at its job. But when you go that extra step into the environments we work in, we're trying to thread that needle. And again, Anthony and I have been working as a dyad for 3 months, but as we continue to move forward, that's the process, is making sure that we're not getting a device that isn't going to work for you in the field, while simultaneously having a device that is relatively easy to train to, maintain, and use.
Well, thank you again for taking the time out of your busy schedule to come to the conference. We really appreciate having you and Director Martin here. Thank you for taking the time to talk with us for a few minutes here today on these various issues that are sort of hot topics in the region right now. And we look forward to continuing to work together in the future.
I look forward to it. The new protocol process starts April 1st. And so, it's amazing. We just barely got through this one, and we're going to be starting again. So I'm very much looking forward to next year and the years to come.
We are too. Thanks a lot.
Thank you, Rick.
Yep.